Thank you, Prof. Thank you, the organizing committee. Actually, I'm today presenting on behalf of a big group, particularly Prof. Abdurrahman al-Sultan, who is currently outside the country. But this is a paper that just have been published recently in BGH this year, a few months ago, just prior to summertime, with a collaboration between multiple centers, including National Guard Hospital Riyadh, the King Fahd Medical City in Riyadh, and King Fahd Specialist Hospital in Dammam, with collaboration with King Saud University, SAFOS, and KMARC. As we're shifting gears to severe aplastic anemia and inherited bone marrow failure syndromes, which are a special entity in the pediatrics age group, and also seeing now more in the adult as well. Cyclophosphamide as a conditioning regimen with a dose of 200 milligram with ATG is often used. However, you could see that cyclophosphamide dose reduction has been used in the context of inherited bone marrow failure syndrome, and the addition of fludarabine to those patients, especially in Fanconi patients, led to a huge success. However, in certain entity of diseases like telomeropathies or the newly diagnosed or identified inherited bone marrow failure syndromes, or what's called in the past unidentified inherited bone marrow failure syndrome, are being more diagnosed these days. And the question all the time, what to do with them? Shall we give them more toxic conditioning regimen? What is the effect of conditioning regimen, alkylating agent, on those patients who could have more prone or predisposition to secondary malignancies? So the data reviewed in multiple centers for children under the age of 14, those patients with severe aplastic anemia, which was idiopathic or presumed acquired or associated with non-Fanconi anemia bone marrow failure syndromes. All subjects had received an HLA match 10 out of 10 match-related donor between 2011 and 2022. The diagnosis of severe aplastic anemia has been done based on the standards that we do all with definitions and investigations, but we always make sure that the chromosomal breakage studies has been done, or a next generation sequencing panel for inherited bone marrow failure syndrome, or plus minus WIS in the later time after 2015 and after. We've used this regimen going down with cyclophosphamide down to 80 milligram per kg as a total dose, of course with fludarabine and ATG as a diagram states. And we have collected around 32 patients. And you could see in red, those are specific patient population with short telomere that was used to be tested prior to next generation sequencing, and others with identified genetic diseases or like mutations that we think it's all pathogenic, like in NKRD26 or ERCC6L2 or TENF2 or RITL1. That's all related to sort of dyskeratosis congenita types. If you look at characteristics and dose and outcome, they're all acceptable, and we can show that in the next diagram. But interestingly, if you look at the ERCC6L2, those patients, we have one patient out of two who developed MDS after that, and then required a second match unrelated transplant, and then after that actually succumbed to a florid AML and then died. This is again, the additional 32 patients with all more of TINF, which is also linked to dyskeratosis congenita. So we could see around 7 to 8 patients with telomeropathies other with other genetic mutations that we don't know exactly what is the best conditioning at that time prior to proceeding with that regimen. And you could look here at the outcome as a whole. The event-free survival is in the 93% with overall survival of 95%. 2 patients experienced secondary graft failure and 1 MDS. But if you subdivide it into acquired severe aplastic versus the ones with non-Fanconi inherited bone marrow failure syndrome, you'll see a little bit of a difference, although here it's not statistically significant because of the numbers. But you see they're almost the characteristic-wise of the transplant itself very similar, except the age, because usually the inherited are younger in age. But the rest are very similar in terms of cell dose, engraftment, GVHD is very close to each other. But you could see at the event-free survival, 100% in the acquired one, compared to 85 in the IBFM. And the good duration follow-up, comparable between 62 months follow-up in the bone marrow failure syndromes versus the severe aplastic anemia. So we concluded from the collaboration that utilizing unrelated, related 10 out of 10 with low dose cyclophosphamide as part of fludarabine based with ATG is very effective in children with acquired severe aplastic and non-Fanconi anemia with inherited bone marrow failure syndrome. Now, numbers in the 32 are limited, but larger numbers are required to establish optimal conditioning regimen for each genetic background. And of course, we had 7 telomeropathy or telomere biology disorders, and all had excellent outcome. And we know that this immunosuppressive approach is now being tried with radiation-free, less alkylating agents to those patients. And finally, the ERCC62 might be of a special interest because of possibly the predisposition, new data is coming of clonal evolution, and whether mixed chimerism has an effect. And immediately in the edition, month after the publication, we got this commentary in the same journal commenting on that changing practice in treating patients with probably inherited bone marrow failure syndrome by the European EBMT group in Italy. And they effectively encouraged and discussed the safety and efficacy of this radiation-free conditioning regimen in the context of match-related donor, but also highlighted things that people could think about. We know this is a heterogeneous group of population. And finally, mixed chimerism may not be an issue maybe in acquired severe aplastic anemia, but rather it's more problematic in some mutations which are connected with clonal evolution, predisposition to MDS and AML. So this issue has not been resolved completely. And with that, I would like to end the presentation, thanking all contributors from all hospitals in the kingdom, and thanking the society here for accepting this and as an oral presentation. Thank you all.
Thank you, Mohammed.